an addiction person working in the field, everybody you see is a drug user. If you're working on this issue, everybody's a drug user. But what I've always been struck by when I look at the literature on infant mortality is they often don't even mention drug use. So if you could just address what might be in some people's minds that the high rates of infant mortality are somehow associated, white people and black people use drugs at the same rate, I wonder if you could address that.
So I was just yesterday writing a column about maternal mortality and looking at all these things that we make up to be reasons that infant and maternal mortality happens. For example, teen pregnancy, that doesn't play out in the data. Drug use, it doesn't play out in the data. And so there are narratives that have been created in the space that people hang on to and hold on to, but they don't, there's no data to support any of those things. There's no data even to support that it's more likely to happen to people who are uninsured, honestly. I mean, most of the people who have deaths are on Medicaid or on some type of insurance, and they have had care. And so what we fail to do is take our own responsibility as a system and how we create these bad outcomes and what we are doing. We've spent a lot of time talking about personal responsibility and what all the moms should do and the women should do, even thinking about you know, the C-section story that you told. A lot of that is we want you to be responsible, and we don't want to take our ownership into what would happen. And even the idea of why we won't do a C-section after you've had, why we won't do a vaginal delivery after you've had a C-section is because we don't want to be responsible for that outcome. We will sue you around that, you know. And so we need to take some ownership that we're all in this together, and there is no most babies that are born addicted live. And we don't even, a lot of them don't even know. There was a study in Florida, you probably all know this, that they did, because the rule in Louisiana was that if you came in with no prenatal care, we would do a UTOX on you. It was like the hospital rule. And so it's, right? And so if the UTOX came back positive, then that's when you get social services engaged and everything else. And so they did a study to see if you did UTOXs, to look at who doctors pick and choose who they want to do toxins on. And it was so based upon race, and honestly, some of the black physicians were one of the worst. Some of the worst, picking, deciding, making assumptions, and when they actually went back and did the toxicologies, it didn't match what our perceptions of the people were. And we've created all these perceptions that are not realities, and so we have to spend a lot of time fixing that. I don't know if that answered your question.
Yes. I have a question. A few of you mentioned that these laws are causing some women to seek out abortion. I'm wondering if there's any data on how often that's happening. Also, if that is persuasive with anti-choice legislators, and also how we talk about that without simultaneously stigmatizing abortion.
So the question as to whether that is persuasive to anti-choice lawmakers, the answer to that is yes. The way that the vote came out in 2014, I think, defied a lot of conventional wisdom on who would vote what way on what. And a lot of very conservative anti-choice lawmakers said they didn't want to vote for this because it would potentially increase the incidence of abortion. And also because a lot of them from very rural areas recognized that there just wasn't treatment available where they were. So the choices that their constituents were going to have to make would probably include wanted pregnancies.
And so no, we don't have the data. I think the piece that we were trying to raise is that this was a situation that could exacerbate that, though, that women would be forced to abort babies that they actually wanted to have. And what was the second part of your question? Because I think you said something else.
Just how to talk about it without stigmatizing abortion.
Yeah. I think that's, I think one thing that I wrote down is that even the ways in which the legislation was written, what kind of flagged for me the way that the legislation was written sounded very similar to anti-abortion legislation. The fact that women were being separated from their fetuses, the fact that fetuses were actually being given a little bit more priority than the mother that was housing that pregnancy, or the fact that they were being separated as if they were not one entity. I think it's something, it's possibly a kind of the point of entry of kind of where we start to begin talking about what this kind of stigmatization could actually look like, or how it plays out for mothers. I think that, as professionals, as healthcare professionals, still lifting up the fact that, at the end of the day, it still is up to the woman about what makes sense for herself, her health, her family, is still a mandate, something that we still feel is really important for medical providers to lift up and to champion on behalf of women. Because for us, and even this is something that I said at the Public Health Association conference last year, that it really is the responsibility of medical providers to be more vocal about why this is problematic. It's really the responsibility of medical providers to talk about the ways in which they have communication issues with their patients right now. I think it's also very important, and not just among yourselves, but to talk about it publicly. I think it's one thing for the large groups like ACOG to say something. I think it's something totally different when in your local community you talk to your DA about the conditions in which patients and you and your patients work along with one another, whether or not women trust the doctor. I know one thing, when I was working in Chicago, we were working with Dr. Melissa Gilliam at University of Chicago, and one thing that she asked our organization to do at that time was just to create information about the harmful effects of douching, because Black women did not want to hear that from a doctor, not believing that douching could lead to low birth weights in babies, or it could lead to bacterial vaginosis and the drying of the vagina and some of these other issues, including pelvic inflammatory disease and all these types of issues, but that it needed to come from Black women in order for Black women to get it. I think in this particular case, there needs to be a continuous reinforcement and destigmatization around abortion care, and for us to start talking about abortion as care, and not this kind of mystified, inflammatory, kind of thing, for us to just kind of to demystify or to destigmatize the ways in which we're talking about abortion, period, but to also lift up the fact that, especially when it comes down to African American and Latino women, that there is fear, undocumented women, immigrant women, that there is fear already built into her experience with the medical community. So that's kind of a roundabout way, but I think that that's at least a beginning point to start talking about it.
All right, that's it for our time. Thank you all very much.